So we'll proceed on to the next talk, and it is again my pleasure to introduce our second speaker, who is Professor Dror, and he is going to talk to us about whether we need to change the targets of weight loss. As I mentioned earlier, Professor Dicker is the president of the European Federation of Internal Medicine. He's also the head of Internal Medicine Department and Obesity Clinic at the Hashron Hospital Rabin Medical Center. So, Professor Dicker, over to you. You can start your presentation. Thank you.
Hello. It is my great pleasure to open my session. My name is Dr. Dror. I'm coming from Internal Medicine D at Hashron Hospital Rabin Medical Center, that affiliate to Sackler School of Medicine in Tel Aviv University. And I am also the current president of the European Federation of Internal Medicine. I'm really sorry that I can't meet you face to face, but I hope next year we will be able to participate in your Congress. And we really want to see all of you in our Congress on March in Malaga. So my talk will focus on the question, can we use target approach in obesity treatment? Here are my conflict of interest, and I don't have conflict of interest regarding to this talk. So we know that in cardiovascular prevention risk factor targets, we have targets for risk factors. For example, the LDL targets. So we know now that the lowest is better, and we really should aim to have below 55 milligram per deciliter LDL in order to prevent cardiovascular disease or secondary prevention of cardiovascular disease. So in hyperlipidemia, we have targets. We have also targets for hypertension and also targets for diabetes. So do we have weight loss targets? So the first targets really ruled by these examples that the regulatory requirements of the FDA and also EMEA for approving anti-obesity medication really set the level of 5% weight loss in order to approve anti-obesity medication. So the 5% was the first target that we aim for because of this regulatory level. So is it true? Is it enough to have 5% weight loss? So if we look on cardiovascular risk factors, we know that to reduce only 5% of your weight maybe is not enough. And we're really aiming now to have 10 to 15% weight loss in order to really have meaningful effect on blood glucose level and even remission. We know now that we need at least 50% of triglyceride reduction, 50% of weight loss in order to really have a meaningful effect on triglyceride, and also 10 to 15% weight loss in order to have meaningful effect on blood pressure and adipose tissue. So the 5% maybe is too low. So let's see. Again, if we look on blood pressure, triglyceride, and HDL and LDL level, the higher the weight loss, the better the effect, as you can see on blood pressure, triglyceride, and HDL and LDL. And also, as I mentioned before, on blood glucose levels, the level between 10% and 15% weight loss have meaningful effect of reduction of glucose level. Now we learn from these phenomenal studies, the direct studies, that showed us that if you really reach 15% weight loss in diabetic patient, you can reach to 70% diabetic remission. Those who lost 15 kilograms in the first year reached 70% of remission in type 2 diabetes. And after 2 years, those who lost 10 kilograms, 64% of them are still in diabetes remission without any anti-glycemic medication. Meaning the 15% in diabetes is maybe the level of diabetic remission. And we also learned from the Look Ahead study, in which they tried to compare intensive lifestyle support to diabetes support, regular diabetes support, in order to prevent cardiovascular disease, meaning 3-point MACE. And in the primary result, they didn't achieve the primary endpoint, meaning reduction in 3-point MACE on those who have intensive lifestyle support. But in the secondary analysis, they showed us that those who lost 10% of the weight really achieved the primary and the secondary outcome. Those who lost 10% reduced the primary 3-point MACE by 21%. And the secondary outcome, meaning CABG and carotid arterectomy and PCI and hospitalization for coronary heart disease, by 24%. So reduction in 10% can really improve the outcome of cardiovascular disease. Now, in this very recently paper, it's a huge study coming from the UK. They showed us that reduction of 13% of weight loss can really have a great improvement, can really lead to great improvement in type 2 diabetes, in asthma, in sleep apnea, in chronic kidney disease, dyslipidemia and hypertension, but not in atrial fibrillation and heart failure or angina pectoris. But this again, the area between 10 to 15% weight loss can really have a meaningful reduction in cardiovascular risk factors and obesity comorbidities. So the 5% is maybe too low, and we should aim to 10 to 15% weight loss, between 10 to 15% weight loss in order to improve cardiovascular risk factors and obesity comorbidity. Now, what about weight loss targets for preventing mortality? So there is no studies that really aim to answer prospectively these questions, but we can see this study that look retrospectively on intentional weight loss. And we can learn from this study that reduce 10 to 15% of weight can lead to reduction of mortality by 33%. Again, a unique study that showed that, again, the reduction of 10 to 15% can lead to meaningful and considerable reduction in mortality. Now, from this SOS study, again, a phenomenal study, they showed us that by bariatric surgery, you can really reduce type 2 diabetes by 78%, reduce cardiovascular death and MI stroke by 33%, and reduce 24% in all-cause death after 16 years of follow-up. Very recently, they published the 23 years follow-up, and they compare people with obesity which weren't operated, people who had bariatric surgery, and people who are in normal weight. Okay, and if we compare those who had bariatric surgery to those who didn't have bariatric surgery, those who had bariatric surgery still had 18% weight loss after 23 years. And this 18% weight loss translates into reduction of all-cause mortality by 23% after 23 years. So again, the area above 15% now translate into meaningful effect in reducing mortality. Now, what about pharmacotherapy and weight loss targets? So we know that lifestyle modification can lead to weight loss between 3 to 8%. And we know that bariatric surgery can lead to weight loss between 16% to 32% in gastric bypass. And this square will resemble the obesity gap, the gap between lifestyle and bariatric surgery. We also know that when we ask people with obesity in the IO action study, Actions IO, that Israel and also the Emirates were part of the 11 countries that participate in this study, most of the people with obesity really aim to have 5 to 10% weight loss. Of course, they expect more, but they really agree to have that loss of 5 to 10% weight loss have meaningful effect on their health. But it didn't really translate into successful weight loss maintenance, okay? Only 10 or 11% of all the cohorts that accounted for more than 14,000 people with obesity really succeeded to maintain 5% weight loss. And only 6 or 5% of all the cohort succeeded to maintain 10% for at least 1 year, meaning that most of the patients do not succeed to really maintain weight loss. And the cost for this is between 4 to 7 attempts of weight loss, meaning the people with obesity invest a lot of effort, time, and money in order to lose weight, but they are failing in maintaining the weight loss. Now, in these guidelines that were published in 2015 by the AACE, they really aimed in a very conservative way to have effect of pharmacotherapy beyond the lifestyle. They aim to 3 to 7% adding effect on lifestyle. So if we look on all the modalities that we have in order to lose weight, we can see that lifestyle again is between 3 to 10%, and pharmacotherapy is again 3 to 10%, compared to bariatric surgery that can reach to really near 40%. Now, if we look on all the pharmacotherapy that we have, we can see that if we look on the targets of 10%, we can reach between quarter to third of all the cohort that can achieve 10% weight loss, which is a very nice percentage. Third of all the cohort using, for example, liraglutide can achieve more than 10% of weight loss. Now, if we look on liraglutide, and this in a very large study program, which called SCALE program, we learn that if we lose liraglutide 3.0 milligram, we can achieve considerable amount of weight loss. For example, in this scale maintenance, in which the run-in period for 3 months include lifestyle modification, and after 3 months, those who lost 5% add liraglutide 3.0 milligram, in the end of the year, the total amount of weight loss was 12.2%, meaning combination of lifestyle changes and medication, in this case, liraglutide, can lead for considerable weight loss. In another study, the scale IBT study, they combined liraglutide 3.0 milligram with intensive behavioral treatment. And again, after 1 year, we can see that more than 10% weight loss was achieved and maintained. Now, if we look on the categorical weight loss, we can see that those who participate in most of the IBT sessions lost nearly 14% of weight loss. Again, the combination of intensive behavioral treatment and pharmacotherapy can lead to a between the 10 to 15% weight loss. So now we are breaking the ceiling of 10% weight loss and achieving the targets of nearly 15% weight loss. To the end, I want to present you two future medications which are not in the market yet, but very promising and very optimistic solution for obesity. Now, the combination of GLP-1 and GIP can lead to combine the effect of GLP-1 and GIP. And in this program, with tirzepatide, meaning the combination of GLP-1 and GIP, tirzepatide, you can see that as long as we increase the dosage of tirzepatide in type 2 diabetes patient, we can lead a very considerable weight loss. So in these surplus studies, in type 2 diabetic patient, using combination of GLP-1 and GIP can lead to substantial weight loss. The second compound is the semaglutide. Semaglutide is a GLP-1 analog that have a T-half of 1 week. The semaglutide acts on several parts in the brain, the hypothalamus and the hindbrain, and leads to, again, a very substantial weight loss. And this program, we can see that in the STEP program, in several studies, they reach 17 to 18% weight loss. And if we look on the categorical weight loss, nearly 80% achieved more than 10% weight loss. So these two compounds are really breakthrough. Again, if we look on the categorical weight loss in these studies, we can see a very nice and very important weight loss. Now, 50% of the cohort lost more than 15%, and 35% of all the cohort lost more than 20%. And this is very promising. So if we look now on this cartoon, the obesity gap now really can be solved, because this gap is now between 60 to 25%, and the pharmacotherapy combined with lifestyle can really achieve the amount of some of the bariatric surgery, and this is very, very promising. So I think that we can conclude that the 15% weight loss should be the new 5% weight loss target. So to the end, I want to emphasize that we have three main goals in effective obesity management. The first one is to achieve weight loss, and we should aim to achieve between 10 to 15% weight loss in order to really treat the cardiovascular risk factors and the other comorbidity. The second, and from my point of view, the most difficult and the most important target is to maintain the weight loss. And this is always become a very hard task. Now, with the pharmacotherapy and the combined lifestyle changes and pharmacotherapy, we can really achieve the maintenance of the weight loss. And the third target is really to reduce diabetes risk and manage diabetes complication, to reduce cardiovascular risk, to reduce functional impairment, and very important, to improve quality of life and reduce stigma. So those three targets are the main obesity treatment targets. And I think with the tools that we have today, the combination of the modality, we can really achieve a successful treatment and maintenance of weight loss. Thank you for your listening and hope to see you in the near future.
Thank you so much, Professor Dror, for that very excellent presentation. You've really demonstrated how important it is for us to go beyond the 15% target in weight loss in order to achieve the cardiovascular benefits. So we have time for a couple of questions. Please go to the mic if you can. Yeah. We'll start with the lady. Yes, please, go ahead. Go ahead. It's not working.
Thank you, Professor Decker,
Yeah,
for a
sorry,
fantastic
I can't
talk.
hear the question, so
I just have
can you
a
repeat it, please?
small question to the last slide. You recommended that the initial weight loss phase, 15%.
No, I can't hear it. Maybe the moderator can repeat it so I can hear.
Yes, we're just waiting for him to finish the question and I'll repeat it for you. Okay?
Thank you very much.
Go ahead.
The problem is, which diet will you recommend in the weight loss maintenance phase? Like high protein, low carbohydrate. We all know that in the phase 1, any diet which contains less calories will reduce weight. Level 1 evidence is already there. But what about the weight loss maintenance phase? Which diet will you recommend for the clinicians at large out here?
So the questions regarding diets during the maintenance phase after the weight loss, what specific diets would you recommend in order to maintain the weight loss that the patient has achieved? Are any... Okay.
Yeah, so this is a very interesting and very important question that does not have an answer, because we know that obesity is very variable and every person has its own diet that can really be successful diet. But what we learned from Israeli studies that really was published in the New England paper, that combination of low carbohydrate Mediterranean diet with physical activity was much better than low fat diet. So usually we are really recommend this combination of low carbohydrate Mediterranean diet with physical activity, but some people will not react very successful to this diet, and then we should really change to low-fat diet. So it's trial and error, and unfortunately we cannot foresee which diet is better in a certain patient.
Thank you. One more?
Okay, thank you so much for the nice speech about the obesity management. My question is regarding the semaglutide as a promising medication, new medication in the pharmacologic treatment of obesity. You have mentioned that it can reduce the weight up to 18%. So what about the optimum treatment dosage and duration for medication?
So Professor Dricker, don't know.
So semaglutide is not prescribed, I think, outside the state yet. So we will really wait for this, and we know that the dosage is between 0.25 to 2.4 milligram in a scheduled dosage. So the best dosage, of course, is 2.4 milligram, because it's the higher dosage. But of course, you should really treat the patient according to side effects. So if the patients can tolerate, and most of the patients in the studies tolerate the higher dosage, so you can really or should treat in the higher dosage. And I think the longest study until now is 1 year, and now there is studies for 5 years that are not published yet. So it's really a very promising breakthrough in the treatment of obesity, and we all hope that the weight loss will translate into diabetes prevention, cardiovascular reduction, and treat the disease with all its comorbidities with this medication. So I think it's a very promising medication.
Thank you very much, Dr. Dror.